All right, well, good afternoon. Welcome to today's webinar, Disorders of Consciousness. So thank you for joining us. My name is Rachel Ishak, and I'm a community outreach specialist at the Brain Injury Alliance of New Jersey. The Alliance is a nonprofit organization with a mission to provide education, awareness, prevention strategies, advocacy, and support for people who've been affected by brain injury. So I just want to announce some things that we have coming up. We are hosting today's webinar, Disorders of Consciousness, and next month we will begin a mini series for brain injury survivors and their families. The first one will be on January 7th on cultivating mental health after brain injury. And so you can register for our upcoming webinars using the link I've placed in the chat, and you can access it there. We also have our regional trainings coming up in March. These are for health and human service professionals interested in learning more about brain injury. We have one on March 6th, 2025 in East Hanover and March 12th in Cherry Hill. And the topic will be building a multidisciplinary treatment team for brain injury care. So I'll be putting in the chat the link that you can use to register for that. Again, it's free and we welcome anybody who would like to join us. So just a few housekeeping notes before we begin the presentation. The attendees' microphones have been muted, so if you have questions during today's webinar, please put them in the Q&A box, and we'll get to as many questions as possible at the end of the presentation. The webinar is being recorded, and so you'll be able to view it afterwards in an email that's sent out, and it will be up on our website as well. At the end of the webinar, a link for a post-webinar survey will be placed in the chat. We really value your feedback and we look at everybody's individual survey results. And so we would encourage you to complete that to give us feedback. And you have to complete the survey in order to receive a certificate of attendance. So if you are looking for that certificate, please complete the survey and you will automatically receive the certificate via email. So today, our presenter is Dr. Brian Greenwald. Dr. Brian Greenwald is the Medical Director of Rehabilitation Specialists. He is the Associate Fellowship Director for JFK Johnson's Brain Injury Medicine Fellowship. And Dr. Greenwald is a professor in the Department of Physical Medicine and Rehabilitation at Rutgers Robert Wood Johnson Medical School and Hackensack Meridian School of Medicine. Dr. Greenwald completed his residency training in the Department of Physical Medicine and Rehabilitation at Rutgers, New Jersey Medical School. He was fellowship trained in brain injury rehabilitation at Virginia Commonwealth University. He is board certified in both physical medicine and rehabilitation and brain injury medicine. And Dr. Greenwald has served on the board of trustees for the Brain Injury Alliance of New Jersey since 2002, and he's currently the vice president. Dr. Greenwald has been the recipient of multiple awards for his clinical work, research, and teaching. And since 2009, he is recognized by his peers through the Castle Connolly surveys as one of the top doctors in the New York metro area. Dr. Greenwald has been extensively published in both peer-reviewed articles and book chapters in the area of brain injury rehabilitation. And currently he is involved in research studies to improve the care of brain injury survivors. So it is my utmost pleasure and honor to welcome Dr. Greenwald today.
Thank you, Rachel. Let me share my screen. Great. People can see my screen?
Yes.
Thank you, Rachel. Well, welcome everybody this afternoon to this important topic, talking about the diagnosis and care of persons with traumatically induced disorders of consciousness. I'm going to be talking a lot in general as far as making diagnoses and such, and we're going to talk about outcomes. We're going to talk about a lot of information. I'm focusing today on traumatically induced disorders of consciousness, people who have had traumatic brain injury, severe traumatic brain injury, and secondary disorders of consciousness. Some of the information may relate also to non-traumatically induced disorders of consciousness, but much of the literature I'm going to be talking about will talk about traumatic brain injury. So an overview, we're going to talk a little bit about traumatic brain injury. We're going to talk about the definitions of disorders of consciousness. We're going to talk about disorder of consciousness outcomes. We're going to talk about medical complexity in patients with disorders of consciousness. We're going to talk about some updated practice guidelines for DOC. and the minimum competency recommendations for programs caring for patients with DOC, and we're going to talk about treatment. So from now on, I'm going to be using the term DOC synonymous with disorders of consciousness. So what are we talking about with disorders of consciousness? Well, I mean, if you look at the lay publications, people talk about coma, right? That disorders of consciousness is coma. But what we really understand is that when people have had a severe brain injury and they're initially unconscious, that they're somewhere in this spectrum of disorders of consciousness. So talking about somewhere between coma, unresponsive wakefulness syndrome, which is the much better and updated name of the vegetative state, the minimally conscious state, and then hopefully the person coming to consciousness. One thing I'm not going to talk much about today, but it's certainly something to think about it also, is that often in between here, between the minimally conscious state and consciousness, is a period of the post-traumatic confusional state, where the person's conscious but very confused and sometimes agitated. I'm not going to talk about that much. It's sort of a whole lecture in itself, and myself and colleagues published some articles about that in the last years. But certainly, it's there is a state where the person's often very confused and agitated between this minimally conscious state and full consciousness. So let's start off by talking about coma. So coma is you got nothing, right? Or as we would say back in Brooklyn, you got nothing. So you have no eye opening, no command following, no recognizable words, no intentional movement. And this is obviously in the absence of paralytic agents, which could make someone look like that. And this results from severe diffuse dysfunction of the cerebral cortices and or the underlying white matter. So this is what we see early on after severe traumatic brain injuries. The person's initially in a coma. Most of the times, the coma phase, where you really have none of these things, lasts for the initial days after a severe brain injury. What we see people then go to next is the unresponsive wakefulness syndrome, of which the former name was a vegetative state. So here we see some change in the brain. We see evidence of restoration of the reticular activating system. And what do we see secondarily? We'll see that the person may have some eye opening. They may look wakeful at times. There may be times that they look like they're asleep. Something. So the real change that we see is that there's evidence of eye opening and wakefulness, which you don't see that in a coma. So again, restoration of the reticular system, the reticular activating system. The change that you see functionally for the person is now eye-opening and wakefulness. But with that said, there's still no evidence of consciousness, right? So there's no evidence that they're aware of themselves or their environment. There's no purposeful or voluntary behavior, so they're not able to follow commands. We may see non-voluntary movements of arms and legs and maybe even their mouth, but no evidence that there's voluntary behavior that's sustained, like showing evidence that they want to do something specifically. No evidence of language comprehension or expression. So what's next is, so what was realized is that the person doesn't go then from being in an unresponsive wakefulness syndrome to full consciousness. Usually there's a period in between where we see some evidence of consciousness intermittently. And Dr. Giacino dubbed this term and created this new phase of disorders of consciousness called the minimally conscious state. So in here we see minimal but definitive behavioral evidence of self or environmental awareness. We can see cognitively cognitively mediated behaviors that may be inconsistent, but there is some reproducibility to them, and so we know that they're not reflexive behaviors. and that there's some awareness, there's some measurable awareness of themselves or the environment on a sustained basis. And generally, the way that we look for those things is that there's evidence that they can follow simple commands, that there's gestural or verbal yes no responses, that they have intelligible verbalizations, and also purposeful behaviors. And so looking for one of these things or one or more of these things would put them at least in a minimally conscious state, meaning that there's at least inconsistent evidence of these behaviors. So my first question when I'm seeing a new patient with what appears to be disorder of consciousness is, where is this person in the spectrum of disorder of consciousness? So we know based on the data by Dr. Schnackers, and this had been looked at in previous studies, that there's a high rate of mischaracterizing patients as being unconscious or being in a vegetative state instead of being in a minimally conscious state using non-standardized evaluations. And as a physician, I think about what I mean by a non-standardized evaluation is, a physician or a therapist or other clinicians coming into the room to someone whose eyes are closed or whose eyes are open. They don't appear to be following any commands. You give them a number of commands. You work with them for 5 or 10 minutes. You don't see any evidence that they're following any commands for you. You say that the person doesn't have evidence of consciousness. That would be a classic example of a non-standardized evaluation. And unfortunately, it's easy to miss evidence of consciousness. And we're going to talk a little bit about more of how you want to be looking for evidence of consciousness in someone who's had a severe brain injury. So why might you miss evidence of consciousness in a person who's suffered a severe brain injury? Well, the person could certainly have severe motor impairment, right? So what are you looking for? You're looking for motor outcomes, right? So you're looking, could they move their arms and legs? Could they move their face? Could they stick out their tongue? Could they open and close their eyes, etc.? If they have severe motor impairment, which certainly can be seen after severe brain injury, it might make you miss evidence of consciousness. If they had severe language impairment, let's say if they were aphasic, right? So let's say you had someone who had a dominant hemisphere injury and secondarily was aphasic. Well, if they had had a stroke and they had a dominant hemisphere injury and they weren't following commands, but they were otherwise awake and alert, you'd say, they're aphasic, but they're conscious. Certainly in someone who had a severe traumatic brain injury, you might miss evidence of consciousness based on them not being able to follow commands because of their severe language impairment. They also may have variable levels of consciousness. You're coming to see them 8 o'clock in the morning, 11 o'clock in the morning, 3 o'clock in the afternoon, but they may show evidence of consciousness at 8 o'clock in the evening because, again, of their variable level of consciousness. Again, another way where you can miss evidence of consciousness and probably accounts for this 40% of the time missing evidence of consciousness with a non-standardized evaluation. So some of the scales that have been used over time to look for evidence of consciousness, well, we think about the Glasgow Coma Scale, which is often done early on after severe brain injury to monitor evidence of arousal or consciousness. The Disability Rating Scale, which includes in a components of the Glasgow Coma Scale score, the Coma-Near-Coma Scale, the Disorders of Consciousness Scale, or the DOCS. And the scale that's both is best accepted now and most widely used would be the JFK Coma Recovery Scale Revised, or the CRS Revised. So the JFK Coma Recovery Scale Revised, which if people are looking to understand this better, one good place to look for it is on the COMBI website, the Center for Outcome Measures in Brain Injury website, which has where you can find the Coma Recovery Scale revised. Certainly, you'd want to, before thinking about applying it or even wanting to know more about it, you want to review it. It's certainly a complex document and a complex scale to administer. But it was really developed to measure small clinical changes in patients functioning at a very low level, both with traumatic brain injury and non-traumatic brain injury. So again, it's for patients with severe brain injury who may appear to have be unconscious, and a way of looking at their level of consciousness and measuring small clinical changes as they're moving along that spectrum of disorders of consciousness. It's been found to both be reliable and valid as an assessment of progress in low-level brain injured patients. When you have a chance to look at the CRS revised, it looks at auditory function and visual function and motor function and oral motor and verbal functioning, communication. There's an arousal protocol that's part of it. And it looks for consistent, reproducible responses and evidence of awareness of themselves and their environment. So some of the things you should know about it, certainly training is critical, certainly at places like JFK and Kessler and Mount Sinai, places that I've spent a lot of time over the years. These are places that have therapists that are very familiar with the CRS revised type thing. Training is certainly a critical part with regards to using it, again, because of the complexity of the work that needs to be done with it. How many times should you do it before you say where the person is in disorder of consciousness? Certainly part of that will be how long post-injury they are and how much they're still changing, under what conditions, certainly to consider. Maybe varying the time of day is something to consider. And certainly something that you'll want to follow the directions carefully. There's a lot of, the directions for this are very detailed, again, going back to the importance of the training. So that's what I knew, right? So come 2010, that was what I knew about disorders of consciousness, or as far as evaluating persons with disorders of consciousness. Okay, so non-standardized evaluations are not so good for this. You can certainly miss evidence of consciousness. The Coma Recovery Scale revised is a very good way of looking at evidence of consciousness. And then there was this article by Dr. Monti that was published in the New England Journal of Medicine. So this was done in an fMRI, and it was looking at. So it first looked at non-injured subjects, and it probably medical students or medical residents or something of that sort. And it looked at two different mental imagery tasks. One was called the motor task, and one was called the spatial task. So the motor task was imagining yourself, so this person is a non-injured person that they started off with first in testing this to look at where the brain activated. So for the motor tasks, they asked the person to imagine that they're there with the tennis instructor, and you're hitting a tennis ball back and forth and back and forth and back and forth. And they found that just by imagining that it lit up on a consistent basis the motor task areas that we can appreciate here on the screen. They then put together a spatial task. So for the spatial task, again, while the person was in an fMRI, the non-injured person in an fMRI, they asked the person to imagine that they are walking around either the place that they live or in a city that they know well, and just looking at things as they're walking around. Again, it's a spatial task. And they found that on a consistent basis, that also lit up a consistent area of the brain that was different than the motor task that the motor imagery lit up. They then took 54 subjects. So that now that they had the normative data, they took the 54 subjects, 23 of which were in a unresponsive wakefulness state or vegetative state, and 31 that were in a minimally conscious state. They found, amazingly enough, that five of these 54 subjects who otherwise were in a spectrum of disorders of consciousness, could willfully modulate their brain activity. Meaning, again, if when given the spatial imagery task, that area lit up, versus when they were given the motor task, that area lit up. Four of those five were considered to be in an unresponsive wakefulness state. All of those had traumatic brain injury. So this was on the cover of the New York Times. Certainly a lot of discussion in the medical world about this afterwards. What does this mean as far as outcomes and such? What do we need to think of with regards to ethical issues? Well, there's been some interesting work that's followed, including very recent. Um, so this is an interesting article published in 2021 that now is looking more both at fMRI and EEG. And this was really a single site work by Dr. Young and Dr. Edlow, looking at the presence of command following on task-based fMRI or EEG, again, in patients who are otherwise disorder of consciousness. And they were using the term here, covert consciousness, right? So things that we're not seeing on physical examination, but yet we could find on fMRI or EEG. Then there's this article that really just came out in August. Again, this is in the New England Journal of Medicine, so a very premier journal. Again, a lot of the folks that are in this art are sort of the leaders of this article, including Yelena Bodian, are some of the folks over at Mass General who have done some of the groundbreaking work on in this topic. But this was a multi-center study, really an international study, and instead of using this term covert consciousness, they now use the term cognitive motor dissociation. So now we're looking at, again, patients with severe brain injury. These patients were unresponsive to commands. And now we're looking at brain activation on fMRI or EEG when presented with these cognitive tasks. So previous studies, like the one that we just talked about, had found that somewhere between 10 and 20% of patients with disorders of consciousness showed evidence of this cognitive motor dissociation, meaning that we show evidence that they have some awareness on fMRI EEG when presented with cognitive tasks. Previous studies had found that patients with cognitive motor dissociation when patients had that, it was associated with a more rapid recovery and better outcomes. In that small percentage of patients, somewhere between 10 and 20%, that who had disorder of consciousness but had this cognitive motor dissociation. So this is a prospective cohort study, 353 patients. It's called a convenient sample in the sense that these are patients who are just coming into the hospital that they were enrolled in the study. It was 3 sites in the United States and 3 in Europe. They looked at both fMRI, EEG, or both when available, and the data collection was between 2006 and 2023. These were all adults with disorders of consciousness. They excluded people with no previous they excluded people with neurologic or psychiatric disease prior to their injury. And also, of course, they had to have no contraindications for MRI, EEG, or both. All the patients were evaluated in the Coma Recovery Scale Revised. Patients then were evaluated with the CRS and also underwent assessment of their response to commands using task-based fMRI, EEG, and all of them were within 7 days before or after that they had the CRS revised redone. So they actually looked a little bit more than just what we were talking about before as far as coma, vegetative state, and minimally conscious state. They broke up the minimally conscious state, as has been done in previous work, into MCS minus and MCS plus. So the definition of MCS minus is that there's presence of signs of consciousness awareness, such as visual pursuit, without response to commands or intelligible verbalization. So these patients have visual, but do have visual pursuit. So MCS plus is patients who have presence of signs of consciousness and awareness that include responses to commands or intelligible verbalization outputs. So it's kind of like a next phase. So the minus is sort of a beginning phase of MCS, and the plus is sort of a next phase. And then obviously looking at people who have emerged from MCS. So of the 241 participants who are unconscious or minimally conscious minus, 25% demonstrated CMD, meaning that they had response to task-based fMRI, EEG, or both. So it's a big number. So these are saying that there's 25% of people who, based on examination, don't show evidence of consciousness, and yet we're finding that on these advanced studies of fMRI and EEG or both. So overall, CMD was associated with a lower median age, brain trauma as traumatic brain injury as the causative factor, diagnosis of minimally conscious state minus, and then the longer you waited to do a CRS, a revised assessment, the better chance that you'd find this. I would guess those are people that are longer post-injury that you're more likely to find the CMD. So this is a multinational study, which kind of gives us more information with regards to that. We found that 25% of participants showed task-based evidence of CMD on fMRI or EEG. This is higher than in previous studies. And the authors, I won't go into it too much, but the authors talk about why it might be that they found this and certainly it creates an interest in how we might more widely use fMRI and EEG in patients earlier on to better understand where they are. Is this a different part of the spectrum of disorders of consciousness? Does this give us more information of how likely they are to recover? You have to recognize that this type of testing, both fMRI and this type of EEG, aren't necessarily widely available in all centers, but certainly might something that may more become a standard of care in looking at these patients earlier on. Like I said, this article was just published in August. It gives us new information to think about for this population. So let's talk a little bit about outcomes just in general after disorders of consciousness in persons who then go from the acute care setting into rehabilitation. So this is a study that I was one of the authors back in 2012. Think about this article that we're going to talk about is going to come up later also. So if you've just been sending texts to other people or sending emails or watching YouTube videos up to this point, start paying attention here. This is a longitudinal study. This is a traumatic brain injury model system study, a longitudinal study of patients with disorders of consciousness. We looked at 337 subjects who were not following commands on admission to rehabilitation. Again, these are all model system centers that we were looking at, data that's been collected since the 1980s. We looked at, like I said, 337 subjects who are not following commands on rehabilitation. One of the results that we found was that 66% or 271 of those patients were following commands on discharge, again, with not a long rehab stay, about 24 days post-rehab admission and about 55 days post-injury. What we found is that 23% of those subjects also emerged from PTA or that post-traumatic confusional state during their inpatient rehabilitation stay. So again, these are patients who are showing up, not showing evidence of consciousness, and a quarter of them actually emerged from post-traumatic amnesia, which is a big milestone during their inpatient rehabilitation stay. We found that of the 128 who didn't regain the ability to follow commands during acute rehab, 76% emerged from PTA by the 5-year follow-up. Again, this is a study that follows people forever. One of the excuses that insurance gives for not admitting patients to acute rehabilitation is that all of them end up in a nursing home anyway, long term. We found in this study that 68% had a community discharge on discharge from acute rehabilitation, meaning they returned either to a private residence or to their group home. Well, here's the critical data, because this will come up again, is that during one or more of the follow-up intervals in this study, that almost 20% of the people who are not following any commands on admission to rehabilitation were actually able to live without in-house supervision during a follow-up interview, meaning in the years post their injury. And that, again, almost 20% of them, 18.7%, demonstrated employment potential in either competitive or sheltered workshop environments. Very large numbers in a situation where oftentimes people are looked at when they have had such severe brain injuries that they're not following commands on inpatient when they got to inpatient rehabilitation, that these people have no hope. This is saying that 20% of people, almost 20% of people, will live in the future without needing in-house supervision, and almost 20% of the people will be able to be employed. So another study looking at outcomes after severe brain injury. This is one of the TRACK TBI studies, also a large multi-center study, and looking at patients with severe brain injury. This looked at people for 12 months follow-up post-injury. They looked at the Glasgow Outcome Scale Extended and the Disability Rating Scale at 2 weeks, 3, 6, and 12 months post-injury, and found that amongst the people who are in a vegetative state at 2 weeks, when you fast forward to 12 months, 78% of those people had regained consciousness. So again, the vast majority, 25% of them had regained full orientation. And when you looked at the Glasgow Outcome Scale Extended, they were considered, more than half of them were considered to have a favorable outcome. And the conclusions that the authors gave from this study was that they recommend not using definitive prognostic statements, certainly during the first 2 weeks post-injury. So I'll switch gears now and talk a little about some of the medical things that I think of when I think of patients with disorders of consciousness who present to acute inpatient rehabilitation, or patients that are being seen in the acute care. I think to myself, based on the studies that I've just discussed with you, lots of the patients are going to wake up who are initially unconscious. What do I need to do as a clinician to help facilitate, to maximize this chance of waking up? So I'm quoting myself here, I have to admit, but I know that patients with disorders of consciousness will rarely improve until many of their medical issues stabilize. And though we think about severe brain injury affecting the brain, we also know that multiple organ systems are affected after severe brain injury. Obviously, the neurologic issues, but anybody who's taking care of patients with DOC recognize also that there's cardiac issues, respiratory issues, immune and infectious issues, bowel, bladder, vascular, musculoskeletal. And if you're going to be someone who takes care of this complex population, you really need to have a general understanding of all the common problems that come out with regards to disorders of consciousness in all these different organ systems. I have to admit, I have a whole lecture that just talks about this one slide and all the issues that are in each of these organ systems. I will, in the 1 hour I have today, I will not be talking too much about those. But, part of the reason that there's a whole fellowship for training in taking care of patients with traumatic brain injury is because of the complexity of taking care of patients with disorders of consciousness and all the organ systems that are involved. Let's switch gears now to this very important paper that came out in 2018. It's actually a set of 2 papers looking at practice guideline update recommendations for patients with disorders of consciousness. And I know most, if not all, the authors that are a part of this paper, and these are the people really taking care of these patients with disorders of consciousness. This article was put together both by the American Academy of Neurology and ACRM, the American Congress of Rehabilitation Medicine, and also the Model Systems Grant, which is funded by the National Institute of Disability Independent Living and Rehabilitation Research. So there was certainly a lot of recommendations that came out of this paper. I would recommend to review these papers, but I'm going to go over some specific ones that I think are so critical as far as advocating for patients and understanding what responsibilities that we have as medical professionals for taking care of patients with disorders of consciousness. So let's look at this first one. So first, clinicians should refer patients with disorders of consciousness who've achieved medical stability to settings staffed by multidisciplinary rehabilitation teams with specialized training to optimize diagnostic evaluation, prognostication, subsequent management, including effective medical monitoring and rehabilitative care. So we're lucky in the state of New Jersey to have great centers like JFK, like Kessler, that have this type of ability to take care of complex DOC patients. Clinicians should use standardized neurobehavioral assessment measures that have been shown to be valid and reliable. That's like what we're talking about when we're talking about the Coma Recovery Scale revised. To reduce diagnostic error, individuals with prolonged disorders of consciousness after brain injury should have serial standardized neurobehavioral assessments. That's like what we were talking about, that how the Coma Recovery Scale revised, it's not something that you just do once. It's something that recognizing that the person themselves is going to evolve, that we want to do that on a regular basis, depending on what type of setting the person's in and how quickly they are evolving. But it's not a one and done type thing, that it needs to be done on a serial basis. And the clinician should identify and treat conditions that may confound diagnosis of disorders of consciousness prior to establishing a final diagnosis. And again, that goes back to the things that we were talking about, is looking at the person in total. So are there other neurologic issues? Is there hydrocephalus? Are there seizures? Are there infection? Are there other diagnoses that might make the person look lower level than they really would be if those things were appropriately treated? When discussing, so this is a level A recommendation, meaning that there's clear literature, scientific literature to support this. Some of these, as you can see, are level B, meaning that there's literature to support it, but not the highest level of literature to support it. But when this statement, when discussing a prognosis with caregivers of patients with disorders of consciousness during the first 28 days post-injuries, clinicians must, and so with a level A, you could use the word must, avoid statements that suggest that patients have a universally poor prognosis. And that goes back to what we were talking about before, about the 20% of patients who go on to have be able to be employed or live independently in the community. The last recommendation is that given the frequency of recovery of patients who recovery of consciousness after 3 months post-injury, that we should avoid using the term permanent minimally conscious state or vegetative state, but to use the term chronic instead, recognizing this they're in a chronic situation more than a permanent situation. So clinicians should be vigilant to medical complications that occur. That's what I was talking about, the importance of clinicians having a good understanding of medical complications that occur after DOC. And certainly the issues with regards to pain and suffering, although there's some controversy whether persons who are unconscious can experience pain or suffering or not. If there's some concern that the person may have a painful condition, we should consider how to best alleviate any suffering that the person may have. I'm not going to talk about children and prolonged disorders of consciousness, but there were some specific recommendations there also. The next is a paper that I was one of the authors on. This is looking at the minimum competency recommendations for programs that provide services for persons with DOC. Again, this is work that we're doing in advocacy and making sure that persons who with DOC that are as complex as that we just talked about, that they have the maximum chance of recovering, and therefore, what are the minimum things that a program should have to be able to improve this person's chance of recovering. So I would recommend, again, I'm not going to go over all the details of this paper, but I'd recommend to pull this paper and to review it. Um, we had 21 recommendations altogether, looking at diagnostic and prognostic assessment, looking at treatment, talking about transition care and long-term care needs, and also management of ethical issues. At the end of the paper, there's a nice checklist for programs so that they can look at how they're doing. Something more recently that we did is to create a consumer version, which is available through the Model Systems Knowledge Translation Center, so that a person whose family is looking for a program to take care of their loved one with disorders of consciousness, that they could ask them and see how they measure up with regards to this minimum competency recommendations. So treatment, obviously, Ben Franklin, it's hard not to think of him when I think of a pound of prevention is worth a pound of cure. And certainly we want in persons with disorders of consciousness early on, we want to try to prevent contractures and skin breakdown and aspiration, ensuring that the person gets appropriate nutrition. Because that type of prevention, it's going to set that person that much more back as far as hoping to recover after a severe brain injury. There's been many studies on different medications to try to improve outcome and improve level of awareness and arousal. Many dopamine agents that have been used for this. The two medications that have been most widely studied in larger studies include amantadine and zolpidem, which the brand name for is Ambien. So in amantadine, there's a study by Dr. Giacino published in 2012. This is a multi-center randomized controlled study of patients admitted to rehabilitation with disorders of consciousness who are treated with escalating doses of amantadine. Patients were, again, somewhere between a vegetative state and a minimally conscious state, and somewhere between 4 and 16 weeks post-injury. They received either amantadine or placebo for 4 weeks. And during this 4-week treatment period, the rate of recovery was significantly faster in the amantadine group than in the placebo group. And there was no significant differences in adverse effects between the patients who were getting amantadine versus placebo. In this study that I was involved with also in the use of zolpidem, so zolpidem or Ambien is known as a sleep medication. It's used generally short term to help put people off to sleep, but it had been found for years earlier to have a paradoxical effect of improving level of consciousness during the 2 to 4 hours that the person has the Ambien in them or the zolpidem in them. Previous studies had found that about 5% of patients with disorders of consciousness had this paradoxical or unexpected effect of improving level of consciousness while the zolpidem was active in their system. This study was done by doing the CRS revised prior to the administration and repeating in the hours after administration. And again, found that about 5% of patients with DOC had a change in their level of consciousness during the active phase of zolpidem. And this study was large enough that I would include it in on one of the potential treatment modalities, although unfortunately only working in about 5% of patients with DOC. Next, we're going to watch a little video together of a TV interview that myself and colleagues had done with a patient who had a very severe brain injury and was in the recovery phase at JFK.
What is that one?
Isn't that a bird?
It is a burger. Good, you came up with that word right away.
He's part of a growing population of Americans suffering from and living with a traumatic brain injury. 19-year-old John Francisco is working his way toward recovery after a gruesome auto accident just 2 months ago.
When I saw him, he was just not moving, tubes all over him. Johnny wasn't there. He was bad.
But in that short time, he's made significant progress, working with occupational and physical therapists every day at JFK Rehabilitation Institute in Edison.
Nice job.
Thanks.
Try and help you at all.
Well, John was not able to speak at all. At all. John did not able to eat at all. They got him to eat here. They got him to speak here. They got him to walk. John was not able to do anything.
The problems that people face after traumatic brain injury, whether it be mild, like we see in concussion cases, or very severe, like we see in Johnny's cases, the needs for those people are very unique to get them to the best care. And there's no doubt that getting the best care will get the best outcome.
And that's why Dr. Brian Green.
Let's watch a more updated video of Johnny.
We last caught up with John Francisco 16 months ago. The Rider University student survived a traumatic brain injury. He was paralyzed on the right side of his body, missing half his skull, unable to speak or swallow. What a difference a year can make.
I've made a great amount of progress. I used to not be able to walk. I know my voice isn't like perfect yet, but I couldn't even talk a while ago. So I've come a long way. I'm going to keep going a long way.
He's gone through intense physical, occupational, and speech therapy at JFK Johnson Rehabilitation Institute to get him here.
The things that you take for granted, as simple as tying my shoe and putting it on, I'm happy and excited I could do these things by myself now.
The hard part is that the external community often looks at brain injury like it's a fractured a leg, like it's a bone fracture, where, you have 6 or 8 weeks of therapy and you get better.
Traumatic brain injury, once thought to be permanent, takes years for recovery. Johnny underwent 11 months of swallowing therapy using a combination of methods, including neuromuscular electrical stimulation.
Take a sip of the water, and I want you to swallow hard and fast, and I want you to really push the swallow. And with each swallowing test that we did, his swallowing changed, and he was able to have honey thick liquids, and then nectar thick liquids, and then finally in March of this year, he was able to do thin liquids, which was fantastic.
But to provide that constant, coordinated care, doctors say it's not always easy to get insurers and the medical community at large on board.
Traumatic brain injury isn't an event that happens to someone like a broken bone. It's a disease process, and we know for sure that people after traumatic brain injury, besides their initial recovery being long and needing a lot of intensive therapies, that they're going to need some level of medical follow-up and supervision and therapies over their lifetime.
Those timid baby steps have turned into a full-on sprint. Johnny is now enrolled in an online course through Ocean County College.
So I've actually been, Mr. Francisco and I've continued to care for him and keep in touch with him over all these years. His injury was in the latter part of, I believe it was 2014. It's been great to see him. You got to see him earlier there. It's just been wonderful to see him continue to improve. He's gone on to get his undergraduate degree, return to all the good things in life, get a job. And then literally last night, John will send me, holiday greetings and such, but he sends me this last night showing that he had achieved his certificate to be a home health aide, just showing his next phase. It's just been wonderful to see all the improvements that he's made. Again, with all the right services that he's got, with the right advocacy that he's got. Certainly his family has played an incredible role as far as his recovery, but it's been wonderful to see him go through all our services over at JFK and just do so well. So in summary, patients, it's possible to have a good outcome, even if patients initially had disorders of consciousness on admit to acute care or admission to rehabilitation. Many of the medical complications are brain injury specific and warrant management by individuals with specialized expertise. Certainly, you want to have easy access to testing to evaluate those for these complications with the appropriate subspecialists to assist with management. And I know the people that care for this population, they recognize that patients after traumatic brain in general are a vulnerable population. We want to make sure that we're giving them the most opportunity to recover as possible. We want to use standardized clinical evaluations to evaluate for consciousness in patients with disorders of consciousness. And certainly be sure, and obviously the Brain Injury Alliance of New Jersey, part of the reason I've been working there for 20 plus years and put my time and effort to this organization is because they're such a great advocacy organization. And individually, we each need to be advocates to make sure that persons with traumatic brain injury and our patients in general get the rehabilitation that they deserve. Thank you very much.
Thank you so much, Dr. Greenwald, for that really informative presentation. And thank you for sharing us a little bit of John's story. So we appreciate that. So we're going to take a few questions now. So if you have any, feel free to put those in the Q&A, but I will start with what is currently there. So our first question for you, Dr. Greenwald, is how will the new ACS/ACRM clinical practice guideline recommendations on the timing of withdrawal of life-saving measures change the field of DOC and brain injury?
Yeah, I have to admit it's sort of a whole topic in itself. There's certainly a lot of controversy about that. I think understanding that, and hopefully through this lecture, you've had a lot of understanding that it's not all terrible. Not everybody has a poor outcome, and certainly advocating that way, recognizing that the decision withdrawal of consciousness or the decision of withdrawal of care should be done after that the family has an understanding of what the outcome really could be. Waiting enough time before considering withdrawal of care. Recognizing also that withdrawal of care can even occur late. I've certainly had this discussion in patients who are months and sometimes even a year plus out in patients who remain disorder of consciousness. It's certainly a controversial consideration of which I think hopefully a lecture like this, of which I've given to many populations, at least opens up people's eyes to what potential outcomes are so that families can make informed decisions about withdrawal of care.
Great, thank you. Next question, are disorders of consciousness terminologies being incorporated into clinician or medical education and qualification standards?
Absolutely. Next question. Absolutely. I know I'm one of the people who writes the exam. So for people who become board certified in brain injury medicine, physical medicine rehab, like myself, neurology, psychiatry, we've been very clear in making sure that people are well aware of this spectrum of disorders of consciousness and the appropriate nomenclature for that. And lectures like this that I've been giving all around the region, and my colleagues are giving all around the country and the world, ensure that.
Great. Awesome. The next question is, are adolescents more likely to have a favorable outcome in their TBI recovery versus adults?
So certainly that there is the extreme. So persons who are much older, maybe who have the comorbidities, are less likely to have a good outcome. And certainly on the other side, adolescents are generally more likely to have a good outcome. But everything always needs to be individualized based on the severity of injury, the acute care that they've had, and hopefully the appropriate rehabilitation that they had. I was talking mostly about adults who suffer from severe brain injury, we're certainly lucky to have good centers like Children's Specialized Hospital, who also does a great job in taking care of children and adolescents with severe brain injury.
Great, thank you. Just take a quick moment to say, if anybody needs to hop off, there is the post survey in the chat, so feel free to fill that out while we continue answering some of these questions that we have here.
I'm also very easily reached. If you Google my name, I think my information through the Brain Injury Alliance comes up. But I'm very easy to reach through multiple sources. If further questions that don't get answered during this time.
Absolutely. Okay, the next question is, do you know of any studies on DOC with people who have a history of aphantasia and cannot use their imagination?
That is an interesting question. I'm not aware of that. It would be, it's a small population that's been studied with regards to the specific things we were talking about in disorders of consciousness, as far as this cognitive motor disorder. And so I don't think the studies are large enough to have really considered that. I haven't personally seen a study like that.
Okay, great. Next question we have, how has medical insurance affected the complete care required for maximum positive outcomes?
Yeah, obviously it's in the news a lot at the moment as far as people's anger about medical insurance and some of the limitations there. I won't go too far into it. I think the important part is that recognize that there's going to be barriers. We need to use the research, the literature that I've just discussed, and try to fighting against those barriers. That's all the people that I've worked with in these publications that I discussed in that second half of the lecture, actually throughout the whole lecture, are people like myself who feel passionate about this area and want to be the advocate for persons with traumatic brain injury and severe brain injury. But that's why we need to continue to push along, to recognize that it's not hopeless, and that we need to be the advocates for persons with disorders of consciousness and their families who often can't be their own advocate.
Mm-hmm. Absolutely. Very good. Well, it looks like that's all the questions we have for now. So I want to thank you so much again, Dr. Greenwald, for sharing your expertise with us today. And
thank you so much, Rachel.
Question wasn't answered, feel free to reach out to me and I'm happy to pass it along to Dr. Greenwald and get you connected there. Feel free to fill out that survey in the chat. We appreciate your feedback. And if you're looking for that certificate, you need to complete that in order to receive it via email. So thank you
everybody.
Appreciate it. And this concludes today's webinar.